Thanks for joining us today for this webinar presented by Nelson Hardiman in collaboration with the American Addiction Treatment Association on addiction treatment, insurance billing, and reimbursement issues. I'm Harry Nelson. I'm joined by my colleague, Catherine Russo. And our topic today, as part of a series on regulatory compliance relevant to addiction treatment programs, is insurance billing and reimbursement issues. I want to note this program is going to address risk issues for providers in submitting claims to insurance. In a future program, we'll be covering the topic of dealing with abuses by insurance companies and non-payment and payment of low rates. But our program today is going to focus on concerns that treatment programs should be focused on in avoiding problems. As an initial matter, please note that the information we discuss today is intended to provide a general guide to certain laws and regulations that apply to addiction treatment facilities. Although we address the issues generally, it's important to take note of the specific laws and the regulations in your jurisdiction that may be distinctive from some of the things that we discuss. As always, the information discussed on this webinar is not intended to provide legal advice, and it should not be relied upon as legal advice. Listening to or watching this webinar does not make us your attorneys and does not create an attorney-client relationship with me or Katie or our law firm. We recommend that you seek knowledgeable legal counsel to take account of the laws in your jurisdiction before you act upon the information in this presentation.
Now we're going to give you an overview of what we're going to discuss in this presentation. We're going to discuss the recent trends in the industry, why it matters, the reimbursement minefield, risk issues such as fraud and abuse claims, issues having to do with the substance of the claim submitted to the insurance company, issue regarding billing of your claim, pre-authorization and verification of benefits, and strategies for reducing these risks.
As a backdrop to this presentation, we prepared this presentation today because of concerns that the industry doesn't fully understand some of the risks that are out there in dealing with the submission of insurance claims, and we hope that the program will be educational. Katie, do you want to talk about recent trends?
Yeah, so recently insurers have been targeting the behavioral health care industry. Many addiction treatment facilities have had their claims sent to the insurer's special investigation units for prepayment reviews. These special investigation units send letters to addiction treatment providers requesting documentation, including medical records and other types of documents. We have also seen insurance companies attempting to recoup fees that have already been paid to addiction treatment programs based on claims that the program didn't meet the insurance company standards for one reason or another. And finally, we've seen that insurance companies increasingly referring addiction treatment programs to state licensing agencies and sometimes to criminal prosecutors.
Just to provide a little bit of background on the subject broadly, the Affordable Care Act in 2010 established minimum essential coverage that included substance use disorder treatment as part of the benefit that health plans were required to provide to their insureds. This was a very significant change. It kicked in 2014 and began to be part of regular health plans. So we're giving this webinar roughly 2.5 years into a new situation in which the availability of insurance claims broadly for much or most of the treatment being given in addiction treatment programs around the country is available. It's really, given that it's a new benefit, it's hardly a surprise that the number of claims submitted grew substantially. As advocates for addiction treatment, we believe that it reflects pent-up need for addiction treatment in the face of a public health crisis around the country. But from the perspective of the insurance companies, it created a massive financial problem. The number of claims being submitted grew significantly and continues to grow, and along with the number of claims, the allegations of fraud and abuse grew substantially. And we're going to talk on this program about different behaviors that are labeled by insurance companies as fraud and abuse. We've mentioned the payers, 6 large payers that are dominant in the California market. Around the country in other states, you'll see many other names on that list. But the common trends that we're seeing and that we're going to discuss today are very much a focal point in the behavioral health industry. and also follow patterns that we've seen as healthcare lawyers in other parts of the healthcare spectrum.
So why does all this matter? It matters because the payment of the claims that you'll be submitting could be delayed during a special investigations unit investigation. Payers may recoup previous payments or suspend payments to treatment programs going forward if the treatment programs are not meeting certain qualifications that the insurance company demands. And treatment programs may end up being referred to state licensing agencies and criminal prosecutors, creating a problem that the provider needs to deal with.
Again, going back to my comment on the last set of slides, the last slide, given the public health crisis of addiction, and the desperate need for services, programs need to understand how to submit claims appropriately and how to bill appropriately. And this program is very much a response to allegations being made by the large health plans that claims are not being submitted appropriately. And the range of responses that can be drawn from what we're seeing out there are quite extreme. At a minimum, we see that when claims go into for insurance services that are in some way incomplete or have some other defect, it delays service. It gives the insurance company special investigation units an opening to investigate, to challenge medical necessity, to challenge the sufficiency of documentation, to question other aspects of the services as being in some way fraudulent or abusive, which we're going to talk about. And in the most serious cases, exposes treatment programs to significant risks. We'll talk more about these things on the slides ahead.
So now to just touch on the reimbursement minefield, some of the issues are fraud, abuse, waste, and overpayment. And we can go through just a brief definition of what each of these are. We have them on the slide here.
So fraud is the most common. You hear the terms fraud and abuse and fraud, healthcare fraud, billing fraud bandied about all the time. In its strictest definition, fraud means an intentional misrepresentation or deception that's made with the knowledge that the deception could result in some payment to which a provider is not entitled. Now, it's very important to note that insurance companies take a broader definition of healthcare fraud than the one that I just gave. From the perspective of insurance companies, anytime a provider submits a claim for a service to which asking for payment to which they are not entitled, the insurance company regards that as a form of healthcare fraud. So using that broad definition, if a provider does not submit documentation that fully substantiates the claim, then inadequate documentation is alleged to be a form of fraud. We think it's very important for providers to assert their rights and to really distinguish between documentation practices which could be improved and real fraud, which is intending to be deceptive. It's very important as a provider that you be aware of what you're permitted to claim for and what you're not permitted to claim for, to make sure that claims are only submitted when you're entitled to be paid. But it's also important to be ready to defend yourself when accusations of fraud are made that are far more expansive. Abuse is the word that goes with fraud all the time. We hear about fraud and abuse. Now, abuse is generally considered to be much broader than specific deception or misrepresentation. And the definition that's generally used in healthcare of fraud and abuse is that abuse stands for healthcare provider practices that are inconsistent with sound fiscal, business, or medical practice, and that result in unnecessary cost or reimbursement for services that aren't medically necessary or that otherwise fail to meet professionally recognized standards. So when you receive correspondence, communication, or allegations from an insurance company that accuses you of fraud and abuse, abuse is really the category of things that were medically unnecessary. Again, you may have insurance companies asserting that insufficient documentation as to what the insurance company expects is a form of fraud and abuse, we take issue with that definition, but I pointed out because providers need to be sensitized and looking for it. Now, waste, sometimes you hear fraud, waste, and abuse. Waste is essentially an accusation that providers are engaging in practices that incur unnecessary costs. This could be something like redundant testing or any cost that's added to the system based on deficient management practices or control. And then finally, the last category that we've listed here as an important term to understand is overpayment. Overpayment is distinct from fraud or abuse. An allegation that there was an overpayment is simply an allegation that you as a provider were paid more money than you should have been paid based on some error that you made or that the payer made. And this is free of any accusation of wrongdoing or fraud or abuse, but it's quite common. And often when we see requests for recoupment, that is where an insurance company, a health plan, has paid and now is coming back later and saying, whoops, we paid you too much, we want our money back. Those kind of recovery or recoupment actions are very commonly based on a determination of overpayment, essentially an error without the implication of fraud or abuse. But I think it's very important when we discuss these things to note that when you receive any correspondence from a special investigation unit, that special investigation unit exists for the purpose of dealing with fraud and abuse.
So what are practices that raise the risk of these types of claims of fraud and abuse? Some of them include procurement of insurance policies for individuals, payment for housing for individuals, failure to collect fees, deductibles, co-pays, or co-insurance, charging an inconsistent rate to different payers for treatment services. That includes charging a different rate to patients with insurance and ones that are paying by cash. Having insufficient documentation, including insufficient documentation of medical necessity and also of proof of payment of the fees, deductibles, co-pays, and co-insurance, and also unbundling of drug testing from treatment services.
So this list is far from a complete, exhaustive list of every practice that could be alleged to be fraud or abuse, but it's sort of a greatest hits compilation of the kinds of arguments that we have seen over the past year coming out of various insurance companies. You'll note if you look at the list that Katie ran through, some of the issues relate to marketing and patient recruitment practices and things like subsidizing or discounting or absorbing the costs for housing, not charging fees, which was the subject of a separate webinar, which we encourage you to listen to if you haven't heard it, and things like charging inconsistent rates. These may not sound like fraud or abuse. Going back to my point on the previous slide, insurance companies take a far broader view of what constitutes fraud and abuse, and these are issues that you may need to deal with and be prepared to defend. And as I mentioned, insufficient documentation is treated in many cases by insurance companies as an indicia of fraud and a form of fraud. As ridiculous as it sounds to say that not completing the paperwork as fully as it might have been completed is fraud, that's absolutely the position that is asserted by insurance companies, and a position that is one that you need to defend, obviously most easily by improving your documentation. But some of the kinds of documentation that need to be documented carefully in your file are medical necessity, that is physician or health professional review to establish the condition, documentation of the person's health status and any kind of evidence to support that health status and support the need for care, and then also documentation of the collection of deductibles and co-insurance relating to the accusation that has been very much the subject of a recent HealthNet investigation about providers discounting or waiving patient financial responsibility. And finally, drug testing has been its own source of fraud and abuse claims. It's been a very active area, both with claims against labs and claims against treatment programs. And so any program that's engaging in urine drug testing should be mindful of the fraud and abuse minefield.
So now we're going to discuss the insurance company's basic fraud and abuse arguments. Insurance companies argue that providers who waive or discount patient fees, pay for housing, or procure insurance for patients are committing fraud and abuse because they argue that this is a potential inducement of the patient to attend the program because the patient might choose your program if you're doing this over some other program. It also is, they argue that it could be a misstatement of reasonable and customary fees and an interference with the contract between the patient and the insurance company. And they also argue that it's a form of deception because the provider charges a different rate to different payers, the insurance company versus an individual paying for cash.
Again, these are only a subset, and we're using these as examples of very prevalent arguments that we are hearing these days from insurance companies, allegations of fraud and abuse that are being made against treatment programs. It's very interesting to note that there are, one of the things to take away from this slide is that the insurance companies are going to be opportunistic about any argument they can make to challenge practices that are leading to more claims being asserted. And it's very important that providers understand what kind of inducements are not permissible. When I say inducement, anything that's given to a marketing referral source or to a patient that encourages them to choose a particular provider is at risk of being called an illegal inducement, or in the more common language of healthcare law, a kickback. And healthcare our laws are full of anti-kickback statutes, both federal when you're dealing with federal health programs and state anti-kickback statutes that apply to private insurance claims that target inducements that are improper. And so anyway, the bottom line is that insurance companies are going to always, at all points, be studying what providers are doing and looking for reasons to challenge those practices as fraudulent and abusive.
So there are certain risks that are related to the substance of claims made, including medical necessity, the accuracy of the claim, and the sufficiency of the documentation, as we've mentioned before.
So with regard to the actual substance of the claim, it's important to note that these are moving targets. The insurance companies are constantly evolving the standard of medical necessity documentation that they expect to see and the level of documentation that they expect to support the services rendered. So these are subjects that require constant attention. It's important also to note that in many places, including California, the standards of medical necessity are changing as the standards of medical involvement in substance abuse addiction treatment changes. So, for example, in California, ironically, until recently, it was illegal to employ or contract with a physician as a addiction treatment program. That's no longer the law, but that was the law for many years. And yet, when it came to insurance billing, it was essential to document that a patient had a sufficient medical necessity for the treatment. The law has now been changed in California to permit incidental medical services to be provided by treatment programs. And the standards are going up for defining the patient's qualification for each step along the way. That is, ensuring that the patient actually needs the help, that the patient is benefiting from treatment, and that something was achieved from treatment. I wanted to make one point here with respect to urine drug testing. With respect to, and this applies to any kind of diagnostic lab testing, the insurance companies really had two distinct complaints about urine drug testing. One was that it wasn't actually ordered by physicians based on a patient review. There was a complaint about the practice of many programs of simply having a standing order for drug testing at some interval, as opposed to having the physician actually examine and approve a particular patient as needing it. But the other important thing to note is that medical necessity also relates to what the physician does with the information. And the claim by the insurance companies has been that if a physician truly believes it's necessary to order urine drug testing, the plans want to see some evidence that the provider is actually reviewing that documentation and doing something with it when appropriate. And so it becomes important to look not only before the fact at establishing that a patient needed a particular treatment, but during and after, noting that a physician actually or other health professional actually reviewed and utilized the information in the course of care for the patient. Also, with regard to sufficiency of documentation, as I noted, there's a little bit of a moving target here because the standards are constantly changing. We know that many programs are still using paper records or are using electronic health record programs that have very sort of formatted and templated records. One thing that we're seeing is that the level of individualized documentation of the patient's condition that's not form-based is important. It's not enough to be using an electronic health record system with a good template. It actually, records need to actually describe the unique things about that patient and really be individuated to the patient. And for anyone who's still using paper records, one of the problems that you are going to run into in sufficiency of documentation is legibility. So there's a little bit of a catch-22. We definitely advocate shifting to electronic health records to protect yourself from claims of document illegibility. But once you shift to electronic health records, you need to be very careful about avoiding a cut-and-paste approach to patient medical records and ensuring that the specific notes that are included on the patient are genuinely individual and reflect that patient's care and condition.
There are also risks related to the billing of the claim, including unbundling, which is when a provider submits bills in a piecemeal fashion to maximize the reimbursement for various tests and procedures, coding accuracy, and upcoding, which occurs when a provider intentionally uses a higher paying code on a claim form for a patient to fraudulently reflect the use of a more expensive procedure or device than what was actually used or was necessary.
So these are all classic problems that have a long history in healthcare and in the dispute between insurance companies and providers over the years that are showing up in behavioral health and in addiction treatment. I'll note it, for example, another example from the urine drug testing context. We've seen over the years that there was a use of different codes, and smart billing companies will often experiment and see how codes will be adjudicated, that is, how they'll be processed by insurance companies. And then once they find codes that work effectively, they'll use those codes to maximize reimbursement. So whenever a billing company is experimenting with codes and submitting codes on your behalf, it's important to remember that they are serving as your agent as a provider. And while there's nothing wrong with billing companies trying to understand how claims get adjudicated and how they get paid, it's very important that providers exercise some oversight and some discretion to ensure that they're not simply turning a blind eye to over-aggressive practices. This was an issue that came up in the urine drug testing context when claims were submitted for thousands and thousands of dollars of individual test G-codes that were being used that insurance companies paid because much of the payment system is automated, and then only came back months and in some cases a year later and said that they had overpaid. It's very important to review those choices carefully and ensure that if there is a bundled code that is intended to be comprehensive, that code is used as opposed to unbundling, which is regarded as a form of fraud and abuse, and also to ensure that your codes are actually accurate and consistent with the services that are being rendered and that are being documented, and to avoid practices like upcoding when you bill at a one code level and in fact provide services for services that were actually at a lower level. We note that there's a distinct, for people who are billing under PHP and IOP codes, this is somewhat simpler, but there's also issues around the billing of health professional codes separate from revenue codes for the program itself. and it's very important to ensure that you are billing consistently and avoiding any kind of redundancy where a code for a health professional is being billed as a professional service under a CPT code when that same professional was really providing service that was included in a PHP or IOP code.
There are also issues surrounding pre-authorization and verification of benefits. Providers should verify a patient's benefits in order to ascertain the amount for which the patient will be responsible. Additionally, payers may require licensure, certification, or accreditation of substance use treatment facilities, and will say that this is a requirement, and they will say that they won't reimburse you unless you have meet their certain requirements.
So just a few extra comments here. First, there are a number of cases around the country that actually provide helpful case law for providers based on verification of benefits and authorization. Essentially, when a provider contacts an insurance company and gets pre-approval, pre-authorization, or does some kind of verification, the provider is effectively transferring the burden to the insurance company of providing accurate information. And there's a nice opportunity in communicating with insurance companies to put the onus on the insurance company to give you accurate information. On the second point on this slide about licensure and certification, we want to note in some states certain kinds of programs are not licensed. For example, in California, outpatient programs are not licensed. They're only certified, and the certification is optional. Now, technically, we get asked frequently, is insurance companies, are they justified in not paying me if I'm not certified in my outpatient program? And it's not that. I want to be clear, that's not a form of fraud and abuse. What's going on there is that insurance companies are setting up their own standard and saying that since there is no licensure of a particular service, the insurance company is going to elect to treat the certification, the optional certification, as the equivalent of licensure, and only to reimburse programs that are in fact certified. That the insurance companies are making an argument. They are not defended by any law in making that argument. You are welcome to challenge it. Our only advice is that it may be a matter of taking on an 800-pound gorilla, and it discretion may be the better half of in simply obtaining the certification and making the benefit process go more smoothly with the necessary certification or accreditation that is technically optional, but simply makes it easier to work with insurance companies.
And to build on what Harry was saying, in some cases, payers have tried to demand repayment for fees that they've already paid for services delivered because the payer discovered that the provider was not, licensed, certified, or accredited.
So this is an important point, and we we included one specific case reference on this slide, a case known as California Physician Service versus Aoki Diabetes Research. California Physician Service was actually part of Blue Shield, and what happened in this case was that Blue Shield discovered that it had paid millions of dollars of claims to a dialysis clinic, and that the dialysis clinic was not structured legally. California is a corporate practice of medicine state, and the only way that the Aoki Diabetes Research Institute could have been structured legally was if it was a physician-owned professional medical corporation, which it was not. So Blue Shield sued Aoki, seeking millions of dollars back on the theory that essentially they had committed a form of fraud and abuse by submitting claims for payment to which they were not entitled. In this case, the California Court of Appeal ruled that Blue Shield was not entitled to any reimbursement because that would result in an inequitable, unfair hardship. That is, Aoki didn't know that it genuinely believed that it was operating in compliance with the law, and it had no way to correct any of those previous claims. And so as to all of the amounts that Blue Shield had already paid, the court ruled that Blue Shield was out of luck. It could not get money back from Aoki. However, as to all of the claims that were unpaid, Blue Shield was in luck, and Aoki was not going to be paid, and the court ruled that it was a legitimate basis not to pay in the first place. So the point here is that the the balance of power shifts significantly after claims have been paid. But as we're giving this webinar, we of course encourage strongly our providers to do everything they can to be in strict compliance. That is, to obtain whatever licensure, certification, and accreditation is necessary to make sure that the appropriate staff have their licensure and certification, to make sure that the documentation is complete, and to make sure that claims go in, as they say, clean. Clean claims are the way to go. We as lawyers can articulate defenses when insurance companies come back after the fact and say that they're entitled to money back, but that is really only a sort of argument of last resort and not something that providers want to rely on unless absolutely necessary.
So let's go over some strategies for reducing your risk. We recommend not procuring insurance for patients.
And on this point, I just want to add, our strong argument is that the line should end with education. Treatment programs should not be involved in the actual procuring of insurance for patients. If patients are not procuring their own insurance, their family members and loved ones may do so. In many states, there are laws about this, and the practice of procuring insurance, of treatment programs, getting involved in the actual procuring of insurance is going to be problematic. It creates an opening for insurance companies to argue that there was some form of wrongdoing. This is a place where the line should end with education and pointing a patient in the right direction, pointing the patient's family to resources so that they can procure their own insurance is okay, but it's a mistake, in our opinion, to go further and actually be involved in the process of procuring insurance.
You should not have a blanket rule that you're going to pay for housing for all of your patients. There are certain exceptions to this, but
and this is an area that has not yet manifested as aggressively as some other practices, but we want to flag. In general, many of the billing codes that are being used are not codes that cover residential treatment. To be absolutely clear, there are some billing codes that actually cover residential treatment, residential stays as part of the services. But in many cases, addiction treatment programs are using codes like partial hospitalization program or intensive outpatient program that do not include a residential component. And in these instances, patients should be paying for their housing, whether it's being provided by the same provider that's providing treatment services or by another provider. Paying for housing, again, is an opening for insurance companies to allege that there is some form of impropriety, going back to our previous slide and all of the arguments that were presented around patient financial responsibility.
Additionally, we recommend keeping sufficient documentation that indicates medical necessity.
And we've covered this in some detail, but again, can't stress enough how important it is to ensure that your documentation meets the standards expected by insurers to establish medical necessity.
We also recommend verifying a patient's benefits.
And in doing so, when you verify a patient's benefits, to the extent that there is a deductible that has not been collected, it's important to collect either the entire deductible if the patient hasn't paid any of it before, or to ensure that the patient exhausts it. There is an active controversy over coinsurance. Insurance companies in some places in the United States are demanding that coinsurance be collected up front. We believe that it's reasonable to wait until a claim is submitted, adjudicated, and you have a determination of an allowed amount of insurance so that you know what the patient's coinsurance amount should be. But the process begins with verifying the patient's benefits.
And to build on what Harry was saying, once you actually do, collect those fees and deductibles, you want to keep a record of that, that you've received payments from patients in case the insurance company asks for those records. You also should keep a record of invoices sent to patients and your attempts to collect payment. You should ensure that your agreements obligate the patient to pay for services that are not covered by insurance. And you should collect proper documentation verifying financial hardship, which is the subject of a separate webinar.
So we'll close just with a final note that this webinar focused on some of the problems that allow insurance companies to assert claims, or that trigger insurance companies to assert claims for fraud, abuse, or to demand repayment, recoupment of amounts that they've paid. We hope that this webinar was helpful in addressing this topic. In a future webinar, as I mentioned at the beginning, we're going to be taking on the topic of how to respond to non-payment by insurance companies, your rights as a provider to challenge and contest non-payment, and some of the challenges that are arising around the amount that is paid to out-of-network providers and the reduction that we're seeing around the country of the amounts being paid in some places. Thank you very much for listening and attending our webinar. If you have any questions, please feel to reach out to us. Our emails and phone number are provided. Thanks so much.